Hello, everyone. This is Shad Reis from CVI 2025. I'm privileged to be with Dr. Timir Paul to talk about uncrossable lesion and what's the algorithm to tackle that. Dr. Paul, thanks for being with us.
Yeah, thanks for inviting. And balloon uncrossable lesion, first of all, is very frustrating situation for interventional cardiologists, and it's usually 2% to 10% cases can happen. And most of the time is due to severe tortuosity of the vessel or maybe severe calcification or both. But one thing I want to emphasize, the balloon uncrossable lesion is a little bit misnomer, meaning that what is balloon uncrossable lesion? You cross the wire, but balloon is not crossing. But if it's microcatheter, does not cross, it also balloon uncrossable lesion.
Yes, yeah.
So how do you tackle that one? So there are not many proposed algorithm. It's not based on any trials or randomized trials or outcomes. It's just kind of based on the experience, right? So you can start with the guide support. Make sure that you have enough support of the good support or increased support. So it can be larger guide catheter, like 7 friends, 8 friends, or it can be different types of shape of the guide that, like, as for example, right coronary artery, maybe the AR1 or AL1, and then sometimes you have to deep engagement of the guide just in case, but guide next option is using the guide liner, often it's helpful, or you can use the wires like body wire technique or like a anchor wire or balloon anchor techniques. So you can have a lot of support there. So first thing, you make sure that you're
Size of the balloon you start with usually?
yeah, that's going to the next. So when you get a good support, and one thing also that you sometimes there is some supporting oil like using the wiggle oil, it helps. Next step would be the what you do size of the balloon. Like there are a lot of options now, 0.8 millimeter to like anywhere from 1.2, 1.5 millimeter balloons. So you start with the smallest balloon, the first step, because it's simple, it's easy to get it. So like 0.85. Most of the time I use the 1.0 like sapphire balloon pro, and then you, if it cross, you go there and then you inflate very high pressure. So it's burst. It's called granuloplasty. And then you make some channel, right? It's called balloon-assisted microdissection. So if that works, then it's relatively easy. Then you can do serial balloon dilatation. And if it's IVES crossed, or you can do CT either one, then you know what you need to do the next.
Yeah.
So that will be the second. And if that doesn't cross, then you can, there are some techniques that smaller balloon, you can inflate as much as you can do, even if it doesn't go, and then push a little bit more, deflate, and then again inflate. Push, inflate, deflate, push, inflate, deflate. That sometimes help. Also, there is another technique that very smallest balloon, just back and forward movement couple of times, that might help. Or
Like darting kind of thing,
technique.
yeah.
Or there are some next step would be the micro catheter, right? It is, there are some specific micro catheters that we can use, such as like a turnpike gold. Like if you screw a turnpike spiral, then you can try to modify the plug and go in. So that would be the next step.
Yeah. Would you use or you start with rotational atherectomy or orbital atherectomy?
No, it should be the kind of third layer or third tier. You can use it. There are utilities.
There's a risk?
There is a risk involved, and there's an expensive device. If, of course, your granuloplasty smaller balloon doesn't work or microcatheter does not cross at all, the next step would be you put if you already have the wire cross, then you can do laser. Of course, some situation you cannot do the laser, but because it is severely calcified, it will not help. But you're just doing the laser to make a channel there. So once you get the channel, then you can do more atherectomy, orbital or
Laser more gentle and less kind of complication or dissection or perforation, right?
And just to get this,
Just a
making
channel.
sure the channel,
Yeah.
that, and then if you want to do the other atherectomy, the problem is that the balloon is not crossing, so you cannot extend that atherectomy wires like Viper's wire or rota wire. That's the challenge, right?
Yeah.
So in that case,
Only think back again to the
back again
granuloplasty.
to the granuloplasty. So there are some technique you can do. If you stuck that situation that you absolutely needed the atherectomy begin with, then, and if you balloon doesn't cross or you cannot extend the wire, one technique I use, especially the orbital atherectomy, keep the nose cone, put in the lesion like a wedge, and then take your workhorse wire out, and then put your Viper or flex, and it usually goes. I have few cases that I showed today.
You'll be sweating a little bit.
Yeah, that is correct.
But
That is correct. But
because the wire is flimsy and
yeah, or it's
doesn't
flimsy,
work. Yeah.
or it doesn't work. So that's challenge. But or very rare situation, I saw some case reports that some people do the microcatheter OSD in and then try to take it out and then exchange your.
Like really jam it in
Yeah.
the. Yeah, interesting.
But again, if you lose the wire and if you cannot go back the wire, if it's really tight lesion, then it's another problem.
Another
So,
problem. You have to recross
you have to
again.
do
Yeah.
this.
But I think microcatheters there it's helpful because you're in the channel, you know where it was. Hopefully you'll have two channels
Yeah,
there.
yeah. But those are the non-CTO cases. But CTO, there are some other techniques that, or double wire techniques, and there's sometimes extra, you have to make a dissection plan, and then you can have some balloon techniques that inflate and deflate in two different wires that can be used. But I'm talking about.
Is there lesion or predictor for no reflow?
That's a good question. I showed I just showed a case today, and I was trying to cross the wire, and with the venous graft intervention, and then just no refill happened completely, and my wire was not down there. So finally, I had to use the microcatheter, and then using the stiffer wire, then I crossed the wire. When I crossed the wire, it's still completely no reflow until I did the granuloplasty. Once you do the granuloplasty, the balloon ruptured, and then Timir.
Inside the graft? Inside the venous graft?
Yeah, venous graft.
Oh.
So that can happen.
So it happened, you crossed, you ballooned, and then you lost flow.
No, without even cross the wire. So I was trying to cross the wire. 2-3 wire I tried, regular walker, so I didn't cross. Whisper wire and run through wire, and then with the microcatheter couldn't cross. Then with the pilot 50, I finally went cross the lesion. But before crossing the wire, it says no reflow completely.
Wow.
It was tight. It was so tight lesion, probably some microemboli went there and just shut it down.
Wow.
But even with after crossing the wire, it's still no reflow. There is no channel. There is no flow there.
So everything showered the native.
Yeah. Yeah. So then.
So did you do nitroprusside, IV, or adenosine?
Yeah, you can try the nitroprusside, and adenosine is the first, probably the make some.
But then balloon.
Once you do the granuloplasty, the smaller balloon, then it's open up.
Wow. These are sweating situation. Did the patient have changes or ST changes or was unstable?
Not much for this particular patient. EF was relatively normal, and then his hematology was
Still
intact, although other graft was gone. But patient having some chest pain at that point.
Interesting.
But not completely hemodynamically unstable yet.
Last question is about when you have non-reversible, do you recommend long wire or short wire?
I do the long wire.
Right.
It's helpful. It's very helpful
Just
for
exchange
exchange
and stuff, yeah.
Like even the wiggle wire, long wiggle wire is very easy to in and out.
Yeah.
So you don't have to.
So you try with a wire doesn't, so you change your long, same wire, and then start till you cross over, and then if you need to exchange over a micro.
Yeah, exactly.
Makes sense.
It's easier.
You don't regret
you
that.
You don't have to use that trapper balloon or others too.
You can trap, as you said, but maybe less hassle.
Yeah.
Well, Dr. Paul, thanks again for walking through this. I learned a lot from this.
Okay.
I watched the videos and others on YouTube channel. This is Shadi Reyes coming to you from CVI in Austin 2025. Thank you so much.